Um, so to start off with, like what does ABDM? ABDM is essentially Ayushman Bharat Digital Mission. So if I had to take the example of what is actually ABDM, so when UPI, all of us in India, like a lot of us in India have, like UPI has become like a de facto mode of payment in India now, and and we have been also trying to push that in other countries, which has simplified payments to quite an extent. So if I have to draw the example, what banks needed to do to essentially enable UPI payments is what ABDM is trying to enable for all the healthcare providers. So similar to like banks who had to upgrade their software, who had to like support the protocols for UPI for them to be able to receive transaction information and settle transaction information between multiple banks. Similarly, ABDM is that infrastructure layer or set of protocols which any healthcare software, uh, whichever is getting used across by any patient or by any healthcare provider, they should be able to upgrade their systems to be able to support ABDM protocols so that interoperability of health information can happen, and patient should be able to use any health application and view information, exchange information, share information, uh, and also like get inputs or alerts and things like that. So that is what ABDM is at its core. Now, what does ABDM intend to achieve? For citizens, it is better control over their medical health records because all of it is getting digitized. Like there is no loss of medical records, no repetitive diagnostic tests, accessing health services and products, because one of the key goals of digitization is also discoverability. So as the health facilities get digitized, as the doctor's information gets digitized, all of that today is easily accessible via Google, via a simple Google search. So as hospitals and doctors start digitizing their existing their existing practices and their information, all of it will start getting into a registry, which will then be easily accessible to anybody wanting to know anything about a particular doctor, essentially a doctor or a hospital or any health product as well. And said, like it saves time in terms of efficacy as well. So in terms of healthcare providers, it can lead to better clinical decision making, with supported by AI and automated workflows. It will promote use of teleconsultations, where like for routine consultations, at least people don't have to like travel long distances. Ease of healthcare records management, and faster and cost-effective settlement of claims. From a policymaker perspective, I think COVID was the greatest example that India could give in terms of like how like vaccination was done in each and every mile of the country, with like super fast accuracy and like in a very short period of time. So essentially use cases like that, where people are able to analyze at a larger ecosystem level. The government is able to look at a larger ecosystem level on what are some of the trends and what are some of the disease conditions, and like uh, what are how are they from a health perspective overall and things like that. And it will also help implement policies effectively at a local level. Now coming to, as I said earlier, what are the core registries? So as I said, one of the key objectives of ABDM is enabling digitization. First is digitization, and second is interoperability. Without digitization, there's no interoperability. So the core building blocks essentially are Aadhaar, which is Ayushman Bharat Health Account. This is a unique 14-digit number for people to be able to to which all their health records get linked. And it also so similar to how we have a bank account and we have an alias, similarly, every individual in the country will have an Aadhaar account, which is mapped to their Aadhaar. And they can also have multiple Aadhaar addresses, where they can like use it for their parents, use it to manage different kind of health records, and things like that. So for example, I could use one Aadhaar address to maintain all my lab records, one Aadhaar address to link all my prescriptions, one Aadhaar address for my discharge summaries and things like that. It depends on the use case that how a citizen wants to use it. And it easily helps capture of demographic information. So one of the classic use cases which has come up in the last few years is patient being able to scan a QR code and share all their health information in the click of a button. So that is one of the things that has come up with regards to ABHA. Second is HPR, which is Healthcare Professional Registry. So this will be an information of all the healthcare professionals who are operating across the country. Uh, and this information can also be then made easily accessible to anybody building a health application, to anybody seeking a seeking a healthcare seeking healthcare, that they can know which of the doctors are verified and which of the doctors are not verified. Then there is health facility registry, which is a comprehensive registry of all health facilities. This includes pharmacies, labs, hospitals, clinics, and all of the entities which are providing care today. And the last is the drug registry. Drug registry is still work in progress, but that will have like a unified drug code across the country for all generic drugs. So that starting from allopathy to Ayurveda. So this is work in progress, and this is what we are trying to build towards as a nation. So as I said, like the first goal being digitization, which is ensuring that everybody who is a part of this ecosystem has a digital ID, and once they start having a digital ID is when they start generating records. So when they generate records, when they create records, when records are mapped, these records are mapped against a digital ID, which then makes interoperability easier. So what ABDM is essentially trying to do is enable interoperability so that multiple applications can talk to each other. Which is say government health programs, ASHA worker programs, which are more public health kind of use cases. And the laboratories, general practitioner, private hospitals. So these are the different entities, as you can see, which are generating some sort of a health information today. So an ASHA worker may be using some different application, government may be like capturing data in some different program, different private companies building different health applications and lockers. Then there are government applications like Arogya Setu, DigiLocker, which also store health data. Private hospitals like Manipal, Apollo, all of them generating their own health data. Laboratories generating their own health data. So ABDM is essentially providing protocols or plugs which will help the different applications to talk to each other, so that if I as a patient walk to a lab today and go to a general practitioner tomorrow, my information should be seamlessly accessible without me having to carry a physical copy of the data. So this is how ABDM looks in action from a stakeholder's perspective. Uh, so say for example, the first step is a hospital or a lab registers in themselves on a facility. Uh, and then the patient walks up to a facility, they scan their health ID at the registration desk. Once they scan, it's all on the phone digitally and available. I just have to open up my camera and scan. So once I scan, all my information is taken from the application, and my information is sent. So the hospital gets all the information about the patient, including the name, age, gender, mobile number, and all of that. The facility then sends a consent request. So all of it is consent driven, where any health information being shared from one provider to the other, from the patient to the provider, from the provider to the patient, all of it is driven by what we call as a consent framework. So the consent framework essentially defines what is the type of data, from when to when the data has to be shared, and who's the provider of the data, who's the owner of the data, and who's the generator of the data. So this whole information is sent within every consent request. Uh, so the facility sends the consent request to the patient requesting access to their medical history. The patient chooses what data to share with the hospital lab and for how long the facility can have access. The consulting doctor sees all that information on on whatever application they're using, and post treatment the patient gets a notification that their medical reports are ready, and the doctor's treatment plan and prescription show up on any application that the patient was using, and medical history as a result is never lost. So that is what ABDM is trying to do from a like, this is how ABDM essentially, the most like basic use of ABDM, which is being able to share information, being able to see information, being able to create like map all my health record to one singular identifier, irrespective of whatever application I'm using, is the core purpose of ABDM. There are multiple use cases which have developed around it, which I'll talk later. So what ABDM is essentially trying to do is follow a more federated architecture. Now, when I say federated architecture, if I talk about NHS UK as an example, NHS UK is a more centralized architecture where the government has access to all the data that is getting generated across any health facility in the ecosystem. But what in ABDM we are trying to follow is to say that, say for example, a hospital A has generated a record and a lab 1 has generated a record. The record by default stays with them. It is only when, so there's no central repository with all health records. So this is a built-in principle for privacy, security, and better user control, and not to burden one ecosystem with the complete responsibility of storing all health records. Because India is as a big country, like we didn't want to overburden any entity or any provider with all the health data. So whoever is the generator of the data essentially uh, stores the data enabled by their healthcare software provider, and like the data gets shared only with consent. So for example, if I'm using application A, I can request, once my data is generated at hospital A, which is using application B, if I request the data on my mobile phone, which is using application A, the data flows from application B to application A. Now, if I walk into application like any other hospital which is using application C, so the data will then flow with the consent from the patient from application B to application C. Application C will only store a copy of the record only for the time duration that the patient is given them access to. Beyond that, the data will be lost. So that is what we mean by no central health repository for all records. And facilities can essentially upgrade their application at any point of time. It is designed to work to be inclusive with or without mobile phones. Uh, it is aligned with India's personal data protection laws, and it has more of an ecosystem approach where the idea is to enable the ecosystem and the private ecosystem to do more innovation on top of it without the government being the sole representative for everything that is getting built. Uh, so as I had explained earlier, sorry, yeah. So the single source of truth, which is what ABDM maintains, is only Ayushman Bharat health accounts, health facility registry, and healthcare professional registry. At the middle of it sits the health information exchange gateway and the consent manager, which stores a list of all the consents that are getting generated, which stores a list of all the health records that are getting generated. So the consent manager in between, which is managing the data, which is built by the government and managed by the government, only has information to how many consents are getting generated, who generated the consent, who approved the consent, and has information that particular hospital, say, but this public health program generated data, this doctor generated data, this diagnostic center generated data. What data was generated does not come to this consent manager. So the government has no access to the data at any point of time. The data is always stored by the health information providers where the data is getting generated. Similarly, on the other side, we have health information user who are just seeing the data, whatever is being generated by the health information providers, and only have access to the data for the duration that the consent is given. So while this transmission of data is happening from HIP to HIU, we follow FHIR protocol. India has defined its own adapted FHIR protocols for the 7 or 8 type of for the 7 or 8 type of health records that are getting consumed. So during the transmission of these health records, like FHIR protocol is essentially used. It is not mandated that the data being generated at the source has to have FHIR servers and all of that, because that is humongous cost. And because that is humongous cost, maintaining a FHIR server, like having FHIR expertise in house, is a challenging task. Which is why the government says that, like, you don't need to implement everything in FHIR at your own native applications. As long as you, during the transmission of data, you are implementing FHIR, we are fine with it. Because that is a common language that can be used for encryption and decryption of the health data. Um, so in terms of like essentially, like for healthcare facilities, how do they start their journey as an ABDM facility? So before that, any questions at this point of time? Happy to take questions if any.
Um,
Or if you want to do questions later, we can do that as well.
Yes, Vineet.
Yes, Vineet, you have raised your hand. You can
Yeah,
unmute and
yeah,
ask.
thanks. Yeah, wonderful till now, Dr. Pradhan. I have two questions. One is about the HFA. So, my question is, if the healthcare entity is a professional health camps organizer,
Hmm.
what kind of registry is available to him? Because he is a mobile healthcare unit,
Okay,
which is not operating out of fixed address. So, what is the recourse for him?
so for them, there are two ways that can be seen. One is they register themselves as a virtual healthcare facility, or so that is one option. The other option is they register themselves under the parent entity. For example, if Piramal is running 10 mobile clinics, they register themselves as Piramal, like Piramal as one unit, and they can have multiple like mobile vans going under it. So mobile vans as such are not treated as any separate entity. Piramal itself can be one health facility registry with the base address of that.
Uh, hello, can you hear
Yeah,
me?
yeah.
Yeah, so we are not having any parent entity. We are the parent organization. We have only this role to have health camps across various states. We do
Hmm.
only this thing. There is no parent building, premises, or entity.
So,
As an organization, we are a mobile healthcare facility only.
okay, sure. But if we are generating, so as I said, if you are generating health data, so generating of health data can be seen from two aspects. One is like if you are a public health kind of a program, you can generate your own data with with the entity being mapped to any, like you can just create one entity which is a
Okay.
public health program, and then create all health records under that. Or the other way of looking at it is also to say that we have a patient application, like we are generating data on behalf of the patient, so the data is still mapped to the health locker where the patient, so it is deemed as the patient is kind of generating the data from for themselves, aided by the
Okay.
mobile health program. But generally all mobile health programs have like one designated facility which they map it to, and then it just makes things much more simpler.
Got it. And the other question is regarding ABHA integration. So, what do you suggest as healthcare providers? We have our own tech system, our own web application, our mobile apps. Should we go for direct integration, or should we use the services of a third party who's providing, is coming like a sandwich between ABDM and us? What
Yeah,
do you
so
think is better?
it depends on the cost consideration, it depends on the bandwidth, it depends on the technical capability. Right now, the
Mhm.
integration process has been significantly simplified. The documentation is also very straightforward. So if you have a dedicated team in house, it should not take more than like
No,
one
we
to
have a dedicated outsourced team, a very competent one, but they are struggling to, integrate because of the instability of the sandbox
so that
environment there.
That used to
Yeah.
be a problem like couple of 1 year ago. Right now, there's a lot more stability in terms of the entire environment. But if they are struggling and if they're not able to integrate, like you can partner with any of the third-party organizations which do provide the service. That's a call which the organization or the business can take depending on the cost implication, because depending on the technical capability and all of that. Both options are open.
Okay. Okay. Is there any customer care kind of thing, or how can we escalate the issue if you can help us? I'm sure I'm digressing. Yeah.
Integration support is the email address. You can just write to them. The team does take a look at all the queries and responds there.
Okay. Thank you very much. Thank you, Doctor.
Sunil, you have raised your hand. You can unmute yourself.
Hi, can you hear me?
Yeah, we can hear
Yeah,
you.
thank you for a nice presentation, Dr. Pradhan. I had a question regarding the use of this data by insurance companies. Because ultimately, I think the adoption will be driven by economic considerations. So, what is the progress on, insurance companies demanding the data in a digital format complying to ABDM for purposes of releasing payments?
So right now NSCX is already live. There are smaller pilots happening. All insurance companies are a part of it. There are specific facilities where enabled by the likes of Vitraya and third-party providers who handle the provider side of the portal. So there are integrations happening and like small pilots going on. So I think like you could connect with the NSCX team directly, and they would be able to help you with figuring out how do you go about integration and all of that. So right now, like I think the pilot is already in shape. There are transactions happening, there are payments happening, but it's not full scale yet in terms of adoption by all the providers. So that will take a due course of time. But all of it is live. Everything is working from a clean section perspective also.
Yeah, that means that the insurance company will be able to very clearly understand what was the treatment provided to the patient. Yeah, what is the procedure, and charge accordingly, right?
Correct.
Make the payment. Yeah, that is quite a complex scenario.
Yeah, all of it is codified. Like it will take its due course of time. But yeah, I think like the pilots are already underway, and like it's a matter of time before things start getting simplified.
Thank you.
You can proceed, Raunaq.
Okay, sure. So kickstarting your journey with ABDM as a facility for healthcare facilities, they can like use any ABDM compatible HMIS. The patient registers with ABHA. The system captures complaints, diagnostics, and treatments in HMIS, and the health record is created and linked with ABHA. And so any ABDM, so essentially like for people who are like wanting to become a part of the ecosystem, they can use any ABDM compatible HMIS where the details are all available, or you can ask your existing vendor also to make themselves compatible with ABDM. So this is how the process generally looks like, where you send request to access sandbox APIs, you get an access after an approval, and then you integrate with the sandbox APIs, you do functional testing and web application security assessment as well. And once the functional testing reports and the security audit reports are submitted, there's a demo which happens with the panel, and post that health tech committee gives an approval, you can go live and implement wherever you want to. So what are the various milestones? Essentially M1 or P1. So M1 to M4 are applicable for health information provider organizations, and P1 to P4 are applicable for organizations which are building health apps and health lockers. So M1/P1 is essentially identity, which is creation of ABHA, verification of ABHA, and scan and share, which is scanning the information and sending information. M2 or P2 is linking health records as a facility or a health locker, and data transfer if an HIU application requests for the data. So you create the data on your system, you tell ABDM that a health record is linked. Only when the HIU will ask for the data is when the workflow says that you are supposed to share the data. So that is M2. M3 is essentially raising and managing all the consent requests and showing the data when received. So from an HIU perspective, I raise a consent which goes to the patient. The patient approves the consent, and then the HIP shares the data to HIU. So the M3 is essentially about managing those consent requests and showing the data. M4 is more of subscriptions and user consent management as a part of the PHR application. And in M4, it is more about ability to create HFR and HPR custom using APIs. So what in ABDM is applicable for me? So if you are an HMIS application which is getting used by hospitals, M1, M2, M3 all are applicable. HFR creation is also applicable. If you are an LMIS application, so M1, M2 is applicable because you need to retrieve records as such, and creating a health facility ID is applicable. For PHR application, P1, P2, P3 is applicable, and building a health locker is also applicable. For public health applications, M1, M2, M3 is applicable. For teleconsultation applications, similarly, M1, M2, M3 is applicable. So these are a few examples of what people are generally building across the ecosystem. So on consumer sides, there's companies like Ekacare, Ambula, Arogyavan, Arogya Setu, all of these building different kind of consumer applications. On provider side, there is 90 plus 91 Bajaj Finserv, eClinical Works, Lal Path Labs on the lab side, Mark on the pharmacy side, Davados on the pharmacy side. So you can see applications all across. So all of these you'll find on the ABDM website itself. And for infrastructure or enabler side, there is Access Health, Finarcan, Vidal Health, which is building more on the provider side of claims. IHX, which is building more on the provider side of claims. YOLO Health building more of a connector for anybody to be able to access those APIs seamlessly. So we see health ATMs, connectors, TPAs, insurance companies, all of them building applications on the infrastructure slash the enabler side of things. So unlocking impact, I think what are some of the possibilities are endless when the value is clear. So essentially, these are a few examples of what are some of the needs that could be focused on in terms of like AI ML kind of applications where we see delayed diagnosis and overwhelmed doctors. So there could be AI for triage, anomaly detection, imaging, and all of that. So Cure.ai is doing interesting work on that space. Nirama is also doing interesting work on that space. So this is more from a digital health perspective and thinking through and helping people think through that, like how do we integrate ABDM, or like if digitization happens, how do we like realize the true value of healthcare from a digitized ecosystem. So the first step is always digitization. Once digitization happens is when we can think of interoperability, we can think of data processing, we can think of signal processing or alerts or medicines and all of that. So from an NLP perspective, I think like Ognito is building an interesting solution on voice-based clinical note-taking. Uh, so from signal processing and IoT perspective, there is reactive monitoring and all of that. So ResApp, Dozy, these are a few interesting companies building interesting applications. And from digital therapeutics like perspective, Visa, Vitafly, these are a few applications which are building interesting healthcare applications. How does ABDM fit into all of it is a question which like the ecosystem needs to think at large in terms of thinking through how we can like leverage more use cases from digitization. So yeah, so that was my presentation. Happy to take any questions.
Dr. Bharat, thank you for introducing us to ABDM ecosystem, how it is growing. I have a couple of questions. First one is when the individual practitioners, when they have to, they have to store the data, and also they have to, if they have to transmit, they have to go through that same M1, M2, that certification process, right? So will there be an infrastructure cost that would be added to those facilities? Will there be an additional needs for them?
No. So I think from a healthcare provider perspective, all that they need to do is go to the website, pick up any application, onboard themselves, and start creating health records. Or if they're already using any software, just ask their vendor to get themselves ABDM compliant.
Okay. And for the fire exchange of the things, again, if that is application is compatible, then it would be able to
it automatically. So from a healthcare provider perspective, it is made as simple as possible that you don't need to worry about any of it. You just need to continue using the application, or if you're not using any digital application, migrate to using some digital application. Start studying the ecosystem.
And this M1, M2, M3 or kind of a milestones that is certified by certain body, or is it like that?
NHRA defines that, and then there are testing agencies which essentially test the application. So this is more from the perspective of people who are building healthcare applications, like how do we undergo the certification and make our application compliant so that there's no data leakage, data privacy guidelines, and all of that is taken care of.
Okay. And another question is, I believe some of the Arbor profiles are, that is fire profiles have been created specifically for Arbor needs compared to the other fire profiles. So will there be, is this being constantly looked at, or how to interchange with other
there was some work required on invoices when pharmacies started coming into the ecosystem. There was some work required on like essentially discharge summaries when insurance companies started coming into the ecosystem. So as and when new use cases come in or new partners come in, like there is revision if the ecosystem feels that no, there are certain data which is not getting captured and things like that. So like that feedback is taken care of and the profiles are also revised. So NRCS is essentially responsible for like maintaining all the profiles. So they're very open to feedback and making changes in the profiles as the need may be.
Okay, okay. And one last question. I think now the discharge summaries are currently can be exchanged as a document instead of purely data. So that is something that is going to be changed in the future.
Sorry, come again.
The discharge summaries from the healthcare providers can be exchanged as a document.
Yeah, discharge summary is a separate document type under ABDM, so they can be shared as that also, or they can be like essentially be shared as a health document also if it's a PDF. So both formats are supported, like structured data also and PDF also.
Okay, okay. But in the future, you would be going more towards structured data. Is that the plan?
Now also, I think all of them are being encouraged to uh, share structured data only. So the idea is to ensure that structured data is getting captured. It might require a bit of effort from the current application to ensure that structured data is getting captured, but like the if it is done, it is better because that will help them only to do analytics and all that later.
Okay.
Vineet, you have a question?
Yes, ma'am. Dr. Pradhan, what is the legal requirement of being ABDM compliant? Is it a mandatory requirement, or is it if we can choose to be compliant or not to be?
There's no mandate.
How does the law?
There's no mandate as such as of now, but once the data privacy like laws come in, like being ABDM compliant will ensure that you are being compliant with the data privacy laws. So right now there's no law.
Okay. Thank you.
So, Dr. Pradhan, it was shown in the second slide, third slide, we are building a drug database where we are giving all the Indian drugs with a unique identifier. So it is like SNOMED or it's already RX norm or something like that, or we are completely building a new structure for it?
No, so I think it is leveraging what CDSO already has and like whatever data sets are, whatever medicine names are already there. The objective is to crowdsource all of this data and build it essentially like as a collective and then exposing it to the wider ecosystem for use.
Okay. Any other question?
Hi Pradhan, very nice talk. It was a very nice overview of the landscape. Just continuing with the thoughts from what Shweta asked. So do you have a in the back end of this whole framework, especially with the drug listing? Do you have a using the CDAX NRCS drug common data? Or we have something else?
Is responsible for maintaining all these masters. So ABDM closely works with NRCS to develop all of it.
Okay. So we have that as right now as a reference map for that.
Right. Yeah.
Okay. Thank you, Pradhan.
Any other questions to Pradhan?
Just one more question. I understand there were some kind of incentives that were given to the healthcare providers to for them to onboard the data or exchange the data, something like that. Is that still in place, Dr. Pradhan?
Yeah, incentives are still in place. The current incentives I think expire June end. There should be a corrigendum sometime soon for extension. The details of it will be out with the corrigendum.
Okay, thank you.
So, Radi, you have a question.
Yeah, thank you, Dr. Pradhan. And I have a very hypothetical question. When I've tried to implement ABDM in South India, especially in Tamil Nadu and other areas, but most of the customers, they really don't want to give their data. They're not really interested in ABDM compliance. What is the kind of pull factor, or what is the how these healthcare providers or the facility providers are taking it and absorbing it? Is there really they are trying to see a value in it?
So right now, to be honest, there's no value from an end consumer perspective per se. It will only come up with time. From an end consumer perspective, it is more about like them being able to standardize and structure all the data together at one place. From a health provider perspective, apart from the incentive scheme, again, they have to see the larger value in terms of what will help them digitize. And so the creation of value is a very subjective question, and that is essentially like a responsibility between the healthcare service provider who's providing them the service, which is a tech company, and the facility themselves, to talk and like discuss as to what value would they get if they start receiving data from outside. It will only help them give better service to their patients, and build more analytics and build more personalized customized profiles for the patients while the patient is coming to their for essentially treatment. So there's no immediate, I would say, clear value add as such apart from the data and analytics side of things, and that will only happen once like more and more people start digitizing.
Thank you. I have another question. We are more from a radiology perspective. I see there are labs being mentioned in your presentation. Is the lab includes medical imaging data or just only the text data?
Sorry, come again.
Okay, so in your presentation, I keep seeing in the facility register labs, hospitals, clinics, pharmacies. I never kind of understood from your presentation the radiology centers, the ultrasound centers who majority deal with only with medical images, not
Right.
text data. So is medical images part of the ABDM, and how that handled in ABDM?
So right now, medical images are a part of ABDM, where you can provide a URL to that image if it's stored in, or a link to that image if it's stored in an S3 or something of that sort. But right now, so far, I think a couple of companies have started integrating the view part of it. How does the, like, because even if I share the data, the consumer on the other side, which is the HIU, still needs to have like a radiology viewer or something of that sort to be able to show the data, right? So I think like those sort of pilots are still happening. I don't think like there are companies who have already started integrating the data or started linking records, but from a view perspective, I think there's some work which still needs to be done in terms of ensuring that if I run a healthcare facility and the radiology center has generated some data, how do I make either my application is compatible enough to be able to show radiology data where I don't have any problem, but if the patient is trying to access the same data, how do they access? So these are a few questions which I think still need to be solved from a patient app perspective, or softwares which are not compatible to show radiology images.
Thank you. Thank you. And that's all my questions. Thanks a lot.
One more question I have is, Dr. Pradhan, like, can you give us some perspective on current adoption and also how the data being exchanged across the healthcare providers and healthcare people that can, the health units that can exchange the data? How is currently the scenario, and where do you see this is going in the next 2 years or something like that?
Yeah, so I think like adoption has started happening. People are starting to integrate. The consumer app side, there's been a lot of essentially focus. But from a like, so this dashboard essentially gives a summary of yeah, so this dashboard gives a broad summary of what are, like, how many healthcare records have been realized, how many scan and share have been done, how many incentives have been done, like how many facilities have been created, what are model ABDM facilities. So this gives a broad summary of like overall like what is the progress across the ecosystem so far. But in terms of real world, I think the government ecosystem progress is going on well. The private like there is like significant adoption among the private ecosystem in terms of early stage companies, but the bigger ones, which is the likes of Manipal, Apollo, and all of that, like some of them have integrated, some of them are in the initial stages of integration. But yeah, like in some form or the other, people are doing it. But yeah, there's still some time to go essentially before all of this starts getting seen in like full flow everywhere.
Okay, thank you.
Any other questions to Dr. Pradhan? Please raise your hand. Otherwise, we can be further. Yep. I think that's all. Thank you so much, Pradhan. Thanks for spending your time and coming here. It's really a nice session for us. Thank you so much.
Thank you so much.
Yeah.